Good morning, and the committee will come to order. With today's consideration of H.R. 2113, the STAR Act, we will take a first bipartisan step to address the issue of high drug prices. So far, in this Congress, we have held full and subcommittee hearings on this important issue. During that time, we've heard from numerous witnesses about how high prescription drug prices in a broken system are causing financial hardship, impacting Americans' out-of-pocket costs, and driving up total health care costs. We have heard from patients like Ms. Ojawumi, who in her compelling testimony before the committee described missing doses, failing to fill prescriptions, and other hardships because of the cost of her medications. My home state of Massachusetts is home to world-renowned healthcare innovation, including drug development. Certainly proud of the work that plays such a vital role in treating diseases and is such an important part of our local, state, and regional economy. But I am also aware of what the high cost of this innovation and how it often gets excessively passed on to the consumer. One of the challenges we face is understanding the problem. The drug companies point to the PBMs, who point to the insurance companies, who point to the hospitals. But we know who isn't to blame: the families, seniors, children, and patients. They are the ones who get left holding the bag of excuses and bad deals, and they are ultimately the ones paying for the problem. Blaming aside, one thing is clear: everybody wants a solution. How to get that solution is important, and it's going to take time, but we take a step in that direction this morning. There is hardly a magic bullet, and bringing this problem under control is going to require multiple changes to our laws. Today's legislation takes a meaningful first step to address a critical part of the drug pricing crisis: transparency. If consumers and payers, like large employers, know more about the drug pricing process, they will have more tools to make informed healthcare decisions and be better purchasers of drugs and medications. This, I hope, can stabilize or drive down overall system costs. The STAR Act takes important steps to promote drug pricing transparency in a number of ways. First, it requires manufacturers to report on the causes of high drug prices. When a product increases more than 10% a year, or 25% over 3 years, manufacturers must report on the cause of that increase. I know there are many companies who are unhappy with this language, as it covers price hikes that occurred in the past 3 years. But we also know and have witnessed how drugs like insulin, EpiPen, and Daraprim have seen large price increases, and we want manufacturers to account for that. I also believe when companies are launching products that cost more than the average Medicare beneficiary's annual income, the public should and deserve an opportunity to understand why the cost is what it is. The STAR Act also directs drug and device companies to publicly report the price and quantity of drug-free samples that they give to providers. We aren't prohibiting free samples, but we are shining a light on little-known parts of the drug distribution system. Notably, drug manufacturers spend significantly more on free samples than they do on direct-to-consumer advertising. Additionally, like the current law requirements in the open payment system, this reporting applies to manufacturers of devices and supplies, as well as prescription drug manufacturers. The simple reason is that all these manufacturers provide free samples, and all of these products have seen costs increase exponentially. The device space can be even more opaque than prescription drugs, and this sunshine is necessary for a well-functioning marketplace. H.R. 2113 also requires the Secretary of Health and Human Services to publish information about the discounts and rebates that pharmaceutical benefits managers, or PBMs, achieve in negotiations. This information would be provided to the public in aggregate by class of drug, but in a way that will not reveal competitive information. This is important because payers like large employers and insurance companies who use PBM services should know which PBM is getting the best discount on drugs that they spend the most on. Transparency will make markets work better. Finally, H.R. 2113 requires a study about the causes of price increases for drugs used in hospitals and implements a Medicare Payment Advisory Commission and Office of the Inspector General recommendation to require all manufacturers to report average sales prices if their drug is covered under Medicare Part B. Today's legislation is a first good step in tackling a complicated problem. I want to thank a number of our colleagues for their bipartisan work on the many important components of this package. They include Representatives Chu, Nunez, Horsford, Reed, Doggett, Buchanan, Boyle, Arrington, and I want to note the work of Jan Schakowsky as well. Representative Spanberger played an important influence in this endeavor as well. Transparency is crucial to increasing our understanding of the market, improving purchasing, and lowering patient and payer costs. Ultimately, innovation is meaningless if Americans can't afford it. With that, I want to thank the effort on the other side for their bipartisan collaboration on this important legislation, and let me recognize Mr. Brady for his opening statement.
Thank you, Chairman Neal, for calling today's markup. 9 years after the Affordable Care Act was signed into law, health care still remains the #1 concern of Americans across the country. The reason why almost always comes down to rising out-of-pocket costs. While Republicans on the committee strongly oppose the recent abuse of the statutory authority of this committee to pursue the President's tax returns for purely political reasons that serve no legislative purpose, Republicans on this committee do stand ready to continue working with our Democrat colleagues to tackle drug pricing concerns and fix our nation's health care system. Republicans are proud to be the party in Congress that led the creation of the Children's Health Insurance Program, the life-saving prescription drug program for Medicare, the Medicare Advantage program for that 20 million seniors depend upon, and the law that originally created the pre-existing condition protections that workers enjoy today. We know that our healthcare industry today needs a major shakeup, and the rising cost of drugs, medicines that patients rely on, means we need immediate and common sense reforms. I agree with the chairman. We often hear a myriad of reasons why the cost of life-saving medicines are so high from those involved in the drug supply chains. Instead of pointing fingers at each other, everyone in the medical community should be identifying what they can do to reduce the cost of drugs for patients. Every actor in the drug supply chain across the healthcare landscape has to take accountability for these unacceptable out-of-pocket costs, because it is not the drug company, the middleman, the prescriber, or the pharmacist that ends up bearing these high costs. It's the patient who, through no fault of their own, can end up having to shoulder a burden they cannot financially bear. This is not fair to a grandmother who has to start working again just to afford the cost of medicines she needs to survive, not for a single dad who has to skip his kid's soccer game because he's forced to pick up extra shifts at work just to afford his prescriptions. We must do better as we work to protect patients and lower health care costs. Congress needs to continue working together to lower out-of-pocket health care costs for Americans by first cracking down on overpriced drugs, secondly, empowering patients to choose the most affordable medicines for them, and thirdly, eliminating incentives in Medicare that reward bad actors and lead to higher prices. Additionally, to protect the hope of future medical breakthroughs, Republicans reject Washington price controls because that will limit Americans' access to life-saving medicines many families are counting on. As the chairman said, the first step in cracking down on overpriced drugs are what we are proposing today, to give the public and Congress more information about how drugs are priced and paid for. Our bill today provides more transparency into drug rebates, more accuracy about drug costs to hospitals and doctors, and more information about drug pricing spikes and high initial prices. The public deserves accurate information directly from the source why these drugs require such a high price tag. Americans want to see more cures and more life-saving medical innovation, and we need to better understand how valuable these remarkable achievements are relative to current treatments. Promoting access to new life-saving treatments is a shared goal at this committee and requires a balance, supporting innovation while also ensuring affordability for Americans. But we know that openness creates informed consumers, and free market competition helps lower drug prices and out-of-pocket costs. I'm thankful that Republicans and Democrats came together to start this conversation on how to tackle and lower these unacceptable costs. But today's bill is simply step one. Legislation before us is not perfect and shouldn't be the end of this conversation. There'll be more reforms ahead. Chairman Neal, I ask you today for your commitment to continue working with us on this bill and this important issue. Because there are many ideas Republicans have brought forward that did not make it in today's bill, such as real-time transparency tools, because patients deserve to know how much they're going to have to pay before they take their prescription script to the pharmacist, as well as making sure cancer patients don't pay more for their chemotherapy treatment based on the site of service, and fixing broken incentives throughout Medicare that may encourage increases in drug prices. But increasing price transparency in the prescription drug supply chain is a crucial starting point as we continue to improve our nation's healthcare system. That is what we are focused on today and deserves our support. With that, I yield back, Mr. Chairman.
I thank the ranking member, and it is clear, based on his comments as well as mine, that our intention here is to consider this the first step. I do think, based on long experience here, that there is an opportunity, given the comments of the administration, members of the cabinet, Republicans in the Senate, Republicans in the House, and Democrats across the board are all consistent in their messaging on this issue, that this is but a first step, and we hope that we can build upon it. My expectation is that we can as well. The committee will now proceed to consideration of H.R. 2113, and without objection, the measure will be considered as read and open for amendment at any point. Let me take the moment to insert into the record the following groups who have offered letters of support based on what we are undertaking this morning: the ERISA Industry Committee, the American Hospital Association, the Center for Medicare Advocacy, AARP, the Federation of American Hospitals, Families USA, the Campaign for Sustainable Drug Pricing, the Medicare Rights Center, and the National Community Pharmacists Association. I believe that those groups have all had a long-term influence and impact on this challenge. So now at this time, let me offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment, and at any point we will consider the base text for the purpose of amendment. Now let me turn to Amy Hall, Staff Director for the Subcommittee on Health, to provide the technical description of the amendment in the nature of a substitute with an emphasis on the changes that were made since introduction. I ask that members hold their questions until after her presentation. Ms. Hall.
Thank you, Chairman Neal. H.R. 2113, the Prescription Drug Sunshine Transparency, Accountability, and Reporting Act of 2019, or the Prescription Drug STAR Act, introduced by Chairman Neal and Ranking Member Brady, includes 5 main components. Section 1 of the bill is the short title. Section 2 of the bill adds a new Section 1128L to the Social Security Act to require manufacturers of prescription drugs to provide a justification to the Secretary of Health and Human Services for price increases. The justification is provided when price increases are in excess of 10% over 1 year or $10,000, 25% over 3 years or $25,000, or for drugs whose launch price exceeds the annual median Medicare beneficiary income of $26,000. In subsection D2 of the new 1128L, the manufacturer would also provide a summary of the justification to the Secretary in an easily understandable format, which the Secretary would post on the website of the Centers for Medicare and Medicaid Services. The manufacturer may exclude proprietary information from such summary. This section also requires reporting of the same information to the Secretary of Treasury and would take effect in 2021. Section 3 adds a new paragraph 3 to subsection A of 1128 capital G of the Social Security Act, and it would require applicable manufacturers report the quantity and total value of product samples provided to all covered recipients. The information would be aggregated per each drug, device, biological, medical supply as applicable. This information would be publicly available posted by the Secretary of Health and Human Services. Applicable manufacturers would also report to the Secretary of Treasury the portion for which they claimed a deduction under Section 162 of the Internal Revenue Code. This provision takes effect in 2023. Section 4 requires the Secretary of Health and Human Services to provide a report to Congress on drugs furnished in the inpatient hospital setting, including an analysis of drugs and shortages, by 2021. Section 5 amends Section 1150 capital A of the Social Security Act and requires the Secretary of Health and Human Services to make public certain information already provided by pharmacy benefits managers. The information made public is currently reported under Section 1150 capital A, subsection B, paragraphs 1, 2, and 3, and would be made public in such a way as to ensure confidentiality of any proprietary information. The bill provides that the data will be reported with respect to the second preceding calendar year to further protect confidentiality. This provision takes effect in 2020. And finally, Section 6 amends Section 1847, Capital A of the Social Security Act to require manufacturers of drugs covered under Medicare Part B submit average sales price, ASP, data to the Secretary of Health and Human Services, regardless of whether the manufacturer has a rebate agreement under Title 19. This provision takes effect in 2020. The amendment in the nature of a substitute makes 5 technical changes to the draft. Changing of to if on page 6, line 13, changing as to at on page 13, line 17, and again on page 17, line 8, and changing each to such at page 13, line 19, and again at page 17, line 9. I would be happy to answer any further technical questions about the legislation that members may have.
The chair would now open the committee for the purpose of questioning our witness, Ms. Hall. Anybody like to be recognized on the questioning front? Chair would move to Mr. Doggett, and then Mr. Nunes will be next.
Ms. Hall, in Section 2 of this bill, as you've drafted it, you call on drug makers to explain why their prices have spiked. And I see there on pages 7 and 8, you've described a long list of important factors that could explain why drug prices spiked, like manufacturing or research cost. But isn't it correct that you do not require drug makers to disclose any of these specifics, but rather leave it entirely to their discretion as to which excuse they want to give?
The manufacturer submits the information which is relevant to the applicable price increase.
Yes. So in other words, it's solely in the discretion of the manufacturer what they submit, which is the opposite of the bill you told me this provision was based upon that Senator Wyden offered and that Congresswoman Schakowsky offered, which requires the manufacturer to disclose the detailed information. I think you have all the right indicators there concerning prices that might justify an increase, but to leave it entirely to the manufacturer narrows the benefit of this. For example, last fall, the president of Nostrum Pharmaceuticals asserted that manufacturers have a moral requirement to sell the product for the highest price. Is there anything in this legislation that would prevent such an assertion being given as sufficient justification?
Mr. Doggett, this 2 points. First, the language in the Wyden bill has the Secretary may include the following factors. So that language is essentially parallel to the language in the bill before us, and that is S474. However, the Secretary would have no basis to know the cause of the manufacturer's price increase other than what the manufacturer reported.
Thank you. And so it is correct then that if the manufacturer says, I'm selling this product because I have a moral responsibility to get the highest price, that would be sufficient under this bill. Similarly, if an insulin manufacturer tells diabetics that are rationing insulin around the country that price hikes over the past 3 years were because they're improving the delivery system for a drug that's existed for nearly a century, that would be sufficient under this bill.
The Secretary would establish the parameters for which the manufacturers report through rulemaking.
Okay, but there's nothing in the bill that requires the manufacturer to do anything. It's entirely to their discretion. Let me mention a second difference between this proposal and Congresswoman Schakowsky's Fair Drug Pricing Act, and that is the development of summaries of what goes to the public, because you're talking about what the Secretary gets. In terms of transparency for the people that need it most, the folks that are suffering from high drug prices, again, it's entirely up to the discretion of the manufacturer what they include in the summary of that information, is it not, under your bill?
The manufacturer provides the summary, which would be posted.
Right. The manufacturer has the sole discretion, unlike the Schakowsky bill, which requires public disclosure of the information except for trade secrets. The manufacturer, in short, can give any excuse it wants to and can give as little of that excuse as possible to the public. And then there's the question of what is the impact of this bill? What does this constitute a true first step? Is it correct that the Congressional Budget Office found that this bill has no cost or savings associated with it?
We do not have an official score from the Congressional Budget Office, but we do not believe that the provisions of this bill will either cost or save the federal government money.
Will not save the Medicare system any money by adopting any of these provisions, according to the informal advice there. And then as to the triggering mechanism, if inflation stays relatively at 0, 1 or 2%, this bill contemplates that none of its provisions will be triggered, even though drug prices may be increasing at 8, 9. In recent years, they've gone up 10% times the cost of inflation. So it could be much higher than the actual cost of inflation or medical inflation before any provisions of this bill are required.
The bill requires the manufacturer to provide a justification if the price of their drug increases by 10% in 1 year or $10,000.
Right. So if inflation is only 1 or 2%, it may be significantly, the drug manufacturer may be able to increase significantly its prices over inflation, as drug manufacturers have been doing without having to do anything under this bill. Thank you.
I'm going to let the witness finish, please. Would you answer that question?
I'm sorry, I'm not clear how to answer the question other than to say the 10% and 25% thresholds were modeled after the NASHB state model law. In addition, we added the dollar thresholds to ensure that if a manufacturer has a very expensive drug, a 10% increase would be tens of thousands of dollars, and that $10,000 threshold would ensure that manufacturers were justifying increases even if the 10% was $100,000. Since it was greater than $10,000, the manufacturer would still have to report, because $10,000 is a lot of money for a Medicare beneficiary to bear as a cost increase.
Thank the gentlelady. And Chair would recognize at the moment that Senator Wyden has put out a statement of support for our work here on price hikes and PBM transparency. With that, let me recognize Mr. Nunez, the gentleman from California.
Thank you, Mr. Chairman. I was pleased that H.R. 2064, the Sunshine for Samples Act, was included in this package. The bill would require companies that manufacture drugs, devices, biologics, or medical supplies to report the aggregate monetary value and quantity of drug samples they give to healthcare providers each year. I want to be clear, this bill in no way prevents drug companies from providing samples to providers, nor does it create any new burdens for healthcare providers. Healthy markets need transparency in order to maintain vibrancy. The Sunshine for Samples Act will collect data on how sample quantities affect the drug market, which will help us better understand what changes are needed in order to lower drug prices for the American people. Finally, I want to thank Congresswoman Judy Hsu for introducing this bill, and I look forward to continuing to work on this critical issue with my colleagues. With that, I yield back.
Thank the gentleman. Let me recognize the gentleman from New York, Mr. Higgins, to inquire.
Thank you, Mr. Chairman. I just wanted to first applaud the work of the committee. Greater transparency in the drug development process is obviously important relative to reasonable pricing. But I also wanted to make an argument in defense of the federal government. The federal government is involved in the front-end basic research of drug development. Drug companies are moving further away from the basic drug development research into the more profitable area of clinical trials to test the efficacy and safety of drugs. 97% of the top 100 best-selling drugs approved by the Federal Drug Administration, Food and Drug Administration, receive research money from the National Institutes and the National Cancer Institute. I also wanted to point out that drug companies the United States is only one of 2 countries where drug companies market directly to consumers. And what they appeal to is not science, but rather emotion. And I think that's something that we have to look at. And then on the far end, the federal government is a massive purchaser of health care generally, and drugs in particular. And when you look at the fact that the Veterans Administration is saving some 40% through negotiated pricing, I think the challenge remains for this body to do even more beyond the transparency that this bill offers toward the goal of reducing drug prices. And with that, I'll yield back.
I thank the gentleman. Let me recognize the gentlelady from Indiana, Ms. Wolarski.
Thank you, Mr. Chairman. Patients often rely on doctors to learn how to properly use a medical device in order to manage their health day to day. For instance, a physician could directly educate a patient on how to use a glucose meter or a syringe for the first time. That could include doing a demonstration with a device sample in the doctor's office. A physician could also show a senior who's about to undergo a hip replacement what the device looks like prior to inserting that in and implanting that in her. Or a senior recovering from knee surgery may want their doctor to show her how to put on a knee brace or help ensure that it's the right size and the right fit. Ultimately, a patient's success with any device is dependent upon knowing how to use it. Patient education is critical to ensure better outcomes for a patient. Ms. Hall, the bill before us today makes a change to the reporting of samples for quote-unquote patient use. Would devices used by a physician to educate a patient about a particular therapy or how to use such device be excluded from reporting under this bill because such devices qualify for the educational materials exclusion under the Sunshine Act?
Thank you for your question. No, those tools, those samples that a physician like a knee or an ankle uses to explain to a patient are exempt under the current regulations. This is the CMS 2013 final rule on the Sunshine Act under the header Educational Materials that directly benefit patients or intended for patient use. And so in the proposed rule, what CMS says is, we understand that patient education is important and we recognize that it may take the form other than written material, especially in the device context. For example, a device manufacturer may give a physician an anatomical model to help explain to patients how a procedure would work. We agree that such an item, which is given to physicians for the purpose of educating patients, falls within the exclusion. This is from page 9486 of the rule.
So there is a new obligation to report products if they meet any of the other exclusions in the Sunshine Act?
Correct.
Well, Mr. Chairman, this is an issue I want to make sure that it's clear. So I ask Mr. Chairman to continue to work to incorporate the stakeholder feedback of this language, and I yield back.
Appreciate the gentlelady's comments. Thank you. Chair would recognize Mr. Reed for the purpose of offering a question.
Well, Mr. Chairman, I believe the topic of concern I had was addressed by my colleague, Mr. Doggett, so I yield back.
Okay. Is there anybody else that would like to ask a question of the witness before we proceed to the opportunity to strike the last word? Dr. Winstrup is recognized.
Thank you, Mr. Chairman. Thank you very much. On the sampling, I want to try and get some idea of what we're trying to accomplish here. I think it's good information to gather, but I guess when we look at it, are we trying to figure out, do drug companies use the samples for marketing or greater awareness of this new product? That I'm sure is part of it. Do they want physicians to have patients have the ability to try this drug before they give a full long-term prescription, which may be costly? Do they want to just help the needy with samples of a thing? Or is it something that we want to find out if doctors are just giving them to their friends who need them? So I guess as we get this information, I'm kind of curious, is there something in there that's driving what we hope to find as far as information that can be useful for us? You know, is it just so that the drug company can have their prescription prescribed more often? Or do we want to have fewer patients start this drug that may be expensive and then have to stop it and have wasted money? Or are we trying to help the needy? Or, you know, and then at the same time, as a result of samples, are we or the patients somehow spending less? Because maybe they're healthier with this, and so the other effects that they were having in their health condition is better, and so they spend less. I mean, I guess there's really nothing in this bill right now that's addressing those issues. We're just gathering information. Would that be correct?
Yes, so as you pointed out, there's nothing in the bill that prevents patients from getting free samples. It simply requires the reporting. The purpose of this reporting, there are a number of independent agencies and studies that have basically said that more transparency about the distribution of samples would enable researchers to study their impact on prescribing patterns and overall costs, and could help payers and health plans target better understanding of what's happening. There's a large body of research that indicates different habits of people that get samples versus those who don't, different spending patterns for providers that give samples versus those that don't. This reporting, while it is not on individual physician, could go a long way in helping researchers and the public better understand those influences on spending. And an example that we have used is Purdue Pharma's provision of free samples during the opioid crisis for 7 to 30-day prescriptions of OxyContin. And perhaps had that information been more publicly available and digestible, it is possible that people could have identified the problem sooner than we did.
Well, I would certainly, especially with the crisis we have that we could see coming, want to know the amount of opioids that are being distributed as samples. But at the same time, I hope that we steer towards, manufacturers have a reason for why they give samples. I would like to know what their reasons are and how we benefit or patients benefit from those samples, and are they, I guess is the question. So you got to imagine they study it, but just getting the numbers doesn't tell us a whole lot. I'd also like to know what the effects are of those samples.
And I think that that is the hope of this legislation, that once this information becomes more publicly available, researchers, and also this, large employers, large health plans can use this information to better understand the effect of samples.
Thank you. I'll get back.
I thank the gentleman. Chair would recognize the gentlelady from California, Ms. Chu, for the purpose of asking questions.
Yes, on the sample issue, I understand that MedPAC has been recommending that there be information given about the free samples that are given out by the drug manufacturers. And they've been saying this since 2009, so it's been at least 10 years. And also, some pharmaceutical companies are saying that, that they already report. But how does this bill improve our understanding about the free samples that are given right now over what is currently happening?
So you are correct in noting that MedPAC has written on free samples. They have a chapter from 2009, which largely talks about a lot of the things that were enacted in law in the Physician Sunshine or Open Payments Act. They've also written about the relationship between both devices and drugs and providers in 2015 and again in 2017. I don't think I'm missing a chapter, but there might be one more out there. And so right now, there is no public reporting. There are a couple of states that may require reporting of free samples given to providers, but this is not, there's no uniform reporting, and this data will be helpful to researchers to say, when this new drug came online or this new device came online, we can now see the shift in spending, and we see that the samples were provided, a massive amount of samples were provided, and that really shifted spending, or there were hardly any samples provided, but people still gravitated toward the drug and can make different conclusions about that.
Thank the gentlelady. Is there anybody else who would like to ask a question of the witness? With that, we'll proceed to the opportunity to strike the last word, and the chair would recognize Mr. Doggett for the purpose of striking the last word.
Thank you very much, Mr. Chairman. Millions of Americans face a daily crisis with how to pay for their prescription drugs. Do I go without? Do I cut the pill in two? Is there some less expensive alternative? Is there a way to avoid financial ruin? While this Congress has been in session over the last 3 months, pharmaceutical prices have been increased on 3,000 different drugs. The soaring rates over an 8-year period, drugs rose in price by an average of 57%, and the prices for drugs with no generic substitutes rose by 142%. That is why this has become a crisis. While bipartisan action is very desirable, and to be sure, Big Pharma has been very bipartisan in wooing this Congress, it is a fundamental mistake to believe that we can join hands with drug makers in a great kumbaya moment and all live happily thereafter. Big Pharma will never voluntarily yield on its monopoly profits. They're just too astronomical, and it's been accustomed to a totally compliant Congress that imposes no meaningful restraint. Even President Trump, with his Rose Garden bully pulpit, with his multiple tweets, with his close relationship with big pharma executives, has failed completely to fulfill his pledge to lower drug prices. The 3,000 increases this year show how much he has failed. The modest changes that the Trump administration has proposed are met with this year's most expensive lobbying and AstroTurf campaign, with daily multicolored newspaper attacks, social media, and television blitz, even attacks specifically on pharma executive Secretary Azar. We will certainly fail in this committee if we merely hold hands and settle for whatever is acceptable to the member of the committee that is most protective of big pharma. We saw again yesterday in the Government Oversight Committee Republican colleagues urging the pharmaceutical industry not to respond to the inquiries that the committee had made concerning drug price information and the development of drugs. Because there is no wonder drug for prescription price gouging, no one piece of legislation that will provide the help we need will do the job. It's appropriate to use multiple tools, and the tool that is being advanced today is one of those important tools, transparency. Transparency, even if done right, only lets us know what pharma is doing and perhaps why, but it will not stop them from doing it. This particular bill tinkers around the edges with a substantially watered-down version of stronger transparency proposals. It permits those who've been engaged in price gouging to disclose what they want to disclose and to hide what they wish. If today's bill becomes law, nobody would pay less and few would learn more. Indeed, one of the endorsement letters to which the chairman referred from Families USA makes the concluding statement, these bills alone will not meaningfully reduce the burden felt by millions of Americans. While multiple legislative steps are necessary, the area that I think will be required ultimately is Medicare price negotiation. That's what Democrats promised last year. Without it, there won't be much change. But that doesn't mean that steps like that taken today are not important. Regarding other necessary changes, I think that the provisions that Congresswoman Chu advances come the closest to taking us in the right direction. She indicates the direction that we ought to go regarding rebate transparency, though these are aggregated, and free drug samples, which had such a harmful impact on opioid addiction. I believe that her good ideas have been constrained, but they are definitely the right direction for us to move. In short, none of the provisions of today's bill, including the one that I personally offered concerning average sales prices for Part B drugs, separately or together, carry us very far along. At best, today we adopt a directional signal that reminds us of the need for action and the big obstacles that lie ahead in achieving it. And I yield back.
Thank the gentleman. With that, let me recognize the gentleman from Mr. Buchanan. The gentleman from Florida is recognized to strike the last word.
Thank you, Mr. Chairman, and Ranking Member Brady for holding this important markup today on a bipartisan prescription drug sunshine transparency, accountability, and reporting act. We know Americans are struggling to afford life-saving medications. This is especially concerning for seniors. In my district, who often live on a fixed income, I hear all the time back home the impact it's having high drug prices on them locally. In fact, I represent one of the oldest districts in the country, number 8, with 220,000 seniors, so these issues are especially important to me and my constituents. We must take thoughtful steps to bring down the cost of overpriced drugs, including giving Congress and the public more information about how drugs are priced for and priced. That's why I teamed up with the Health Subcommittee Chairman Doggett to introduce the Reporting Accurate Drug Prices Act of 2009, which was included in this bipartisan package. Our bill requires all Medicare Part B drugs manufacturers to report pricing data to the Department of Health and Human Services to ensure that the taxpayers are spending efficiently. According to the GAO and Medicare programs, the beneficiaries spend billions of dollars on Part B drugs, which is based on data provided by manufacturers. Without complete information, Payment rates can be inaccurate, which is why the GAO and HHS, Medipac, and the President's budget have all called for Congress to enact this important measure. Thank you, Chairman Doggett. I look forward to continue to work with you. Moving forward, I hope we can continue to work on a bipartisan way to help lower drug prices by promoting competition in the market while encouraging innovation. With that, I yield back.
Will the gentleman yield before yielding back?
Yes, I will.
I just want to thank you for joining on this measure. As you know, the Inspector General found that there were 200 manufacturers of Part B drugs that had not submitted this average sales price data, and an additional 45 manufacturers that were not required by previous law. We have the recommendation of the Inspector General and the work of MedPAC, and there is a belief that this could eventually have some impact on Medicare payments, though we acknowledge it won't make any difference in the prices that seniors are paying. But I think it is a constructive step, and it would not have happened without your participation. Thank you very much.
And thank you, Chairman. And I'll just add just quickly that I think it's a good step in the right direction. Thank you.
Thank both gentlemen for their commentary. And let me recognize the gentlelady from California to strike the last word, Ms. Chu.
Thank you, Mr. Chair. And thank you for moving today's markup on Ways and Means so that we can tackle the skyrocketing prices of prescription drugs. Today is an excellent first step, and I look forward to our committee continuing to work on this issue throughout this Congress. I'd especially like to thank Chairman Neal for including my bill, H.R. 2064, the Sunshine for Samples Act, which I introduced with my fellow Californian colleague, Congressmember Nunez. The Sunshine for Samples Act closes a loophole in the Sunshine Act and requires drug and device manufacturers to report to the Secretary of the Department of Health and Human Services the total aggregate monetary value and quantity of drug samples that they give to healthcare providers each year. This is important because in 2016 alone, pharmaceutical companies gave the equivalent of $13.5 billion in free samples to medical providers. Free samples can be an important way to help patients afford high-cost drugs, but they also serve as marketing tools and have the potential to impact the behavior of patients and providers. For example, over a decade ago, drug manufacturers who produce OxyContin and other opioids participated in an aggressive marketing campaign that's been linked to the opioid crisis in medical reviews. The drug manufacturer Purdue used free patient coupons to provide 7 to 30-day supplies of OxyContin to patients who hadn't used the drug before. At the end of this marketing program, more than 34,000 of these samples had been redeemed, and it's estimated that up to 50% of the patients who used OxyContin were at risk of becoming addicted. What's more, these free samples are part of the business model of pharmaceutical companies. Drug makers offer free samples because they work. They encourage the use of their product. In fact, from 1997 to 2016, pharmaceutical companies spent more on free samples than they did on direct-to-consumer advertising. Additionally, drug companies are able to deduct the value of these samples as a business expense. This is an important part of the landscape in the demand and price of drugs, and right now we know very little about this whole thing. In fact, MedPAC recommended all the way back to March of 2009 that Congress require drug makers to report information about the free samples that they give out. Specifically, MedPAC noted that this information would allow researchers to study samples' impact on prescribing patterns and overall drug costs. In a subsequent report in June 2017, MedPAC also recommended that Congress require medical device manufacturers to increase transparency in their pricing. Like with pharmaceuticals, requiring the report of the value of free device samples that manufacturers give out will paint a more complete picture of the cost of these devices. That's why the Sunshine for Samples Act requires that all samples, pharmaceuticals, biologics, and medical devices be included in these reporting requirements. The more information we have about the whole market for healthcare, the better we will be able to make policies that bring healthcare costs down and decrease costs to patients and the taxpayers. As we in Congress seek ways to lower the cost of prescription drugs for our constituents, it's essential that we have a clear picture of what's happening in the market. There are certainly other blind spots within the prescription drug market. I'm excited to see several others addressed in this bill as well. But again, samples have an important role to play in helping patients afford expensive drugs, and this bill does nothing to prevent companies from giving out free samples. It does, however, help the American people gain insight into the business of prescription drugs. The Sunshine for Samples Act is an important provision of H.R. 2113, and I strongly encourage my colleagues to support the bill. I yield back.
Thank the gentlelady. Let me recognize the gentleman from New York, Mr. Reed, to strike the last word.
Well, thank you, Mr. Chairman, and I'd like to start by thanking my colleague from Nevada, Mr. Horsford, for working on the Spike Act that's been included in the markup today, and I thank the chairman for this hearing to get at this important issue of the ever-increasing drug prices we see across America. To me, the Spike Act is a reasonable bipartisan step towards creating transparency in Medicare drug costs. The government reimburses manufacturers for these drugs, and we in Congress are simply asking them to explain to us and to taxpayers why such launch prices and annual price increases are so high. We are giving manufacturers a great deal of flexibility to tell us their story about the value of a drug, and repercussions are only triggered by misrepresentations in their materials supplied to HHS and justification. We still have questions about the drastic increases in the cost of drugs like insulin over the past few years, and Congress, taxpayers, and patients want some more answers. We are concerned that if drug manufacturers continue to charge high launch prices and increase drug costs year over year without any publicly available information about why, Congress will continue down the road toward price fixing and government overreach in this area. We'd much rather create some transparency in the drug market instead and give manufacturers an opportunity to discuss value where opaqueness and consequently a negative perception of the industry and its practices exist now. And so I appreciate this effort and in this markup, and look and ask our colleagues to support the Spike Act as it goes through the process. And with that, I yield back.
Thank the gentleman. Let me recognize the gentleman from Pennsylvania to strike the last word, Mr. Boyle.
Thank you, Mr. Chairman. I move to strike the last word. Thank you for convening today's markup. The public spoke loud and clear in the last election. We must bring down the unreasonably high cost of prescription drugs in America. Today is our first step to do exactly that. I am pleased that this first step is bipartisan, as ideally this subject should be. Today's bills represent common sense steps to bring greater transparency to the prescription drug market in order to empower consumers and policymakers alike to make informed choices going forward. I was proud to introduce one such bill included in H.R. 2113, and that's H.R. 2115, the PBM Accountability Act, along with Congressman Arrington as well as Congresswoman Spanberger, to make prescription drug pricing more transparent and ultimately make medications more affordable. Pharmacy benefit managers, or PBMs, do essential work negotiating on behalf of consumers, and they are critical to containing overall costs for prescription drugs through market-based tools that encourage competition. However, market-based tools can only be as effective as any market is transparent. As such, we must bring these negotiations out into the full daylight in order to ensure consumers are reaping the benefits of negotiated discounts. The PBM Accountability Act would require the HHS Secretary to make publicly available online aggregate rebate data and generic dispensing rates, data PBMs already report to HHS by law. Information on rebates by class of drug would be made publicly available as well, with limited pro-consumer exceptions. This transparency would enable patients, doctors, employers, and other buyers to better understand and be able to compare the discounts PBMs receive and make informed purchasing and prescribing decisions accordingly. AARP released a report recently, and it found that transparency laws were correlated with slower price growth. Price hikes of prescription drugs slowed just when transparency laws like the STAR Act were considered at the federal level. I would request that this report be entered into the record.
So ordered.
Only through greater transparency can we empower consumers, achieve real accountability for drug pricing crisis our nation faces, and craft lasting solutions to this problem that severely impacts so many American families. I am proud that today we are taking this first important and necessary step. With that, I yield back.
Thank the gentleman for his inquiry. And with that, let me recognize the gentleman from Nebraska, Mr. Smith.
Thank you, Chairman Neal and Ranking Member Brady, for bringing us together for this markup. Prescription drugs are vitally important to all Americans. Every one of us are here included. Advances in science and technology have opened the doors to treat or cure thousands of diseases which used to be considered a death sentence. I think Americans appreciate the life-saving advances pharmaceutical research has brought us, but it's easy for consumers to become frustrated by the cost of these new and innovative drugs. Even more frustrating is when the price of a medicine they have been using for an extended period of time goes up over time, as opposed to many other newly researched and developed consumer products like phones or televisions, where the price becomes more affordable as the time on the market grows. And it's understandable why consumers would have questions. This package under consideration today represents an important first step in bringing much needed attention to a complicated issue, and transparency which will help both Congress and the public to better understand the impacts of prescription drug spending and shortages and the reasons behind significant price swings. However, this is just the first step in a longer process. The conversation on this issue must continue as the legislative process continues to make sure that our efforts actually result in tangible savings to patients. As this conversation continues, we should take a close look to make sure the standards we set actually incentivize robust competition in the marketplace and continued innovation, and are not arbitrarily set for show or to single out a particular class or category. I trust that as the legislative and implementation processes continue for these initiatives, the emphasis will be on setting fair, meaningful standards which incentivize healthy competition and innovation going forward without forcing significant time and effort to be expended relitigating past actions. Thank you. I yield back.
Thank the gentleman. Let me recognize the gentleman from Nevada, Mr. Horsford, to strike the last word.
Thank you. I move to strike the last word. Mr. Chairman, thank you very much for your efforts in bringing the STAR Act before this committee. I am pleased to see the inclusion of my bipartisan bill, the SPIKE Act, in the drug transparency package, and I would like to particularly thank Ms. Amy Hall for her work in meeting with me and our staff on this legislation. The SPIKE Act, which I introduced with my colleague Congressman Tom Reed of New York, would require drug manufacturers to publicly justify their large price increases and high drug prices launches to the American people. For far too long, manufacturers have not had to provide any explanation for their price hikes, leaving us with a system that is simply untenable for patients. It has been a privilege to work on this legislation, which provides important transparency measures for patients and taxpayers. I would like to note for the record, Mr. Chairman, that under page 9, line 20, does give the Secretary the authority in regulations to determine elements to go into the summary based on previous questions that were raised by Mr. Doggett. It is without a doubt that the rising cost of prescription drugs has left families teetering on the edge with high out-of-pocket costs, and with it, an increase in high health care spending and insurance premiums. The drug price crisis has become all too familiar, and it is also extremely personal. It is for me. I have personally experienced and suffer from health complications, and as a result, I will likely depend on 5 prescription drugs for the rest of my life. And that is the case for most Americans, especially those that live with diabetes. It is unconscionable that drugs like insulin, which have been available for nearly a century, are becoming inaccessible for those who need to stay healthy. Yet, from 2002 to 2013, the total cost of managing diabetes in the United States increased dramatically, from $92 billion in 2002 to $263 billion in 2013. That period witnessed an increase of 197% in the price of insulin. This is obscene, and the American people are owed a justification for these astronomical price increases. Let's use the example of a gallon of milk. If we compared the rate of increase of insulin to the price of a gallon of milk, a $5 gallon of milk would now cost $14.85. And that's not even the worst offender. Duexis, a common anti-inflammatory drug used to treat arthritis, went from $140 in 2011 and soared to $2,979 for 90 pills in 2018. At this rate, this $5 gallon of milk would now cost $105. I'd like to spend the remaining portion of my time sharing the story of Brenda from Pahrump, who is one of my constituents who has experienced the rising cost of her life-saving medications. Brenda suffered from a stroke caused by a small hole in her heart. To treat her condition, she relies on a drug called Xarelto. After taking this drug for 3 years, the price went from a manageable $130 for a 3-month supply to $443 because of an undisclosed increase in the price. Ladies and gentlemen, that is nearly 3.5 times the original cost of her medication. Brenda was never made aware of why her medications increased in price, but she had to bear the brunt of this steep increase. Without legislation in place, we will never know why these drugs keep going up and continually stretching the American people's budget. Lastly, let me close by commending my home state of Nevada and my good friend, Nevada State Senator Ivana Kinsella, who introduced a bill which required diabetes drug manufacturers to disclose information about their price hikes. And this kind of insulin price disclosure is critical for Nevadans. I'm proud that Nevada has served as a leading example for this body and the rest of the country. And I yield back my time.
Thank the gentleman. Let me recognize the gentleman from Ohio, Dr. Winstrup, to inquire. To strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. I'm glad we're having this discussion on transparency in our healthcare system. I think it's very, very important. I encourage this committee to actually expand our scope on these efforts and bring greater transparency to more parts of our healthcare system. For example, transparency on the cost of identical care provided in a physician's office and hospital outpatient departments. You know, I recognize that hospitals have certain requirements that other medical facilities do not. They're required to have decontamination sites, and the list goes on. And I understand that for that very purpose, that a higher reimbursement for them may be necessary. But I think that the increase in fees should be based on services associated with hospitalization and true emergency care, rather than some of the things that are being done on an outpatient basis, and sometimes a completely different site. So a recent study in the Journal of American Medical Association Oncology found that outpatient cancer care costs at least twice as much in a hospital outpatient department in comparison to a private practice, and this is by both disease type and episode of care. And too often, patient doesn't know that they're left paying more. And this isn't just care that's provided within what we know as their local hospital, but it's in a facility owned by the hospital. So in the interest of reducing out-of-pocket costs for cancer patients and reducing costs to the taxpayers, especially for those that require regular drug administration, I hope we can make a commitment today to act to reduce out-of-pocket costs for drug administration that is taking place across America, especially for our cancer patients. Really, seniors should not have to pay more simply because their physician is now employed by a hospital. I think we need to take a close look at that, and I hope we continue down this path of revealing more transparency within our healthcare system. I yield back.
Thank the gentleman. With that, let me recognize the gentleman from New Jersey, Mr. Pasquale, to strike the last word.
Thank you, Mr. Chairman. Today, our committee is taking a small but very significant step towards our shared goal of addressing drug pricing. I want to particularly associate myself with the last two speakers, one Democrat, one Republican, who are addressing very significant problems with what we're dealing with right now. And to have anecdotal stories to support the presentation is overwhelming. We all have those anecdotal stories. Transparency around our convoluted drug pricing and coverage system can hold bad actors accountable. I believe that. Requiring drug manufacturers to justify high price increases and launch prices for drugs and making this information public will make manufacturers accountable and provide necessary information to consumers. Sunlight is always the best disinfectant. Our country is a leader in healthcare innovation, and we will continue to be. These bills do nothing to detract from that. In fact, the provisions within can help the industry tout some of the amazing scientific achievements they are making to improve our health care. Patients should know more about the prescription drug costs that affect their out-of-pocket expenses. Too many Americans have been negatively impacted by massive price increases. As was just mentioned, the 1.5 million Americans who have type 1 diabetes, insulin is a life-saving drug, and a lot of times it's in sparse supply, which makes the situation even worse. The price of insulin, a drug discovered in 1923, roughly doubled to $450 per month in 2016 compared to the $234 per month in 2012. These high costs have forced as many as 1 in 4 people with diabetes to ration or skip doses. We know that for a fact. We recently learned that one particular drug manufacturer whose aggressive marketing of highly addictive opioid generated $35 billion in revenue for a single drug, oxycodone, patented a new form of buprenorphine, which is a medication used to treat opioid. How clever. While Americans become dependent, addicted, overdosed, we ought to look at our own medicine cabinets. And even died, the price of oxycodone rose. The manufacturer sought to increase profits by selling a treatment for the oxycodone. Medicare prescription drug spending, which reached $129 billion in 2016, it's only expected to increase in the next decade. We must do everything we can to protect and strengthen Medicare for the future. As more specialty drugs come to market, pricing transparency for payers and patients and taxpayers is extremely vital. I have not had any subject that I've talked with my constituents which turns into so many horror stories than with the subject of drugs, prescribed drugs. And people don't know what to do about it. And for a change, we're trying to do something about it. Thank you, and I yield back.
Thank the gentleman. With that, let me recognize the gentleman from Illinois, Mr. Davis, to strike the last word.
Thank you, Mr. Chairman. The high cost of drug medications has gotten out of hand with little hope in sight. There are those among us who believe that in our capitalistic society, that it's okay to make as much money as possible, regardless of the impact on the rest of society. Health care should be a right and never should be about extreme profits at the expense of patients and taxpayers. The cost of prescription medications are steadily climbing in costs exponentially over the past several years, and unless something is done about it, it will put healthcare delivery in a terrible position. Some analysts have reported about half of all Americans take a prescription drug. This issue, if not already, will be the central most critical problem Americans will face in their lifetime. Many Americans are put in a place to choose whether to fill their prescription drugs or pay the rent and or feed their children. A story from one of my constituents in Chicago about the high price of drugs, named Thomas, stated, "I pay $7,000 out of pocket for my prescriptions, and that is with insurance." He went on to suggest that this is completely insane. We must have a multi-pronged solution regarding the high price for drugs. H.R. 2113, the Prescription Drug Sunshine Transparency, Accountability, and Reporting Act, is a compilation of certain provisions of 4 bipartisan bills that were introduced this year. This legislation is a first step towards changing the landscape of the current drug pricing problem facing patients and taxpayers. While we are addressing this prescription drug crisis, let us be mindful of how best policy initiatives should address insurance industries that utilize a manufacturing model or algorithm to create formularies based predominantly on acquisition cost and utilization. The formularies are created with an inherent assumption of an illness model or of one size fits all, with little appreciation for the heterogeneity of patients or illnesses. There's a growing body of evidence that the insurance companies' fail first philosophy leads to higher health costs later due to increased emergency room visits and hospitalizations. In some conditions, fail first or use of older, cheaper medications lead to an unnecessary and avoidable worsening of the patient's condition. The delays in obtaining medication from prior authorization therapies often discourage patients who then stop all medications. The implementation of fail first step therapy has 2 additional undesirable consequences. It has created an artificial market for generics, causing rapid price increases, shortages, and price gouging, such as the EpiPen story or the recent article in the Washington Post, Investigations of Generic Cartel Expands to 300 Drugs. Step therapy allows a drug manufacturer to block the placement of competitors' product on a formulary through discounts and rebates, which reduces access to products to patients that could obstruct best practices. Present formularies do not frequently incorporate precision or personalized medicine in many diseases, nor have the flexibility to provide safe and effective medications to illnesses that are heterogeneous or have unpredictable clinical courses. I commend Chairman Neal and Ranking Member Brady for introducing 2113. I support this bill and urge its passage and yield back the balance of my time.
I thank the gentleman. With that, let me recognize the gentleman from Georgia, Mr. Lewis, to strike the last word.
Mr. Chairman, I move to strike the last word. The high cost of prescription drug is the top issue the American people want us to fix. The American people want to know. They want to know what is in the food they eat, the water they drink, the air they breathe. They want to know why their medication costs so much. The drug pricing has been so secret for too long. We need to put some sunshine on the pricing of drugs. We should move very, very fast on this bill. Congress needs the information so we can do our job and do it well. This markup and the bill is a first step to tackling drug prices America facing today. We can do better, we can do much better, but this is only the beginning. With us cooperating and working together in a bipartisan fashion, we can do it, and Mr. Chairman, we must do it. And I yield back.
Thank the gentleman, and let me recognize the gentlelady from Florida, Ms. Murphy, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. I want to express my support for the STAR Act, which will increase the transparency of drug prices so the American people can better understand why the cost of a medicine they rely on has gone up, as so many have in recent years. Drug makers will have to justify high launch prices and large price increases. The government and the public will be able to scrutinize the soundness of the arguments they put forward, which could dissuade drug makers from pursuing unwarranted price hikes, saving money for patients and taxpayers. The bill also requires other stakeholders in the drug supply chain, such as PBMs, to increase the disclosures they provide to the public. Transparency is a necessary step to lowering drug prices, but it is not, on its own, a sufficient step. This bill is the first in what will be a series of actions by this committee and other committees to make prescription drugs more affordable. It starts with transparency, but it does not end there. My constituents in Central Florida, like their fellow Americans around the country, are anxious and, quite frankly, a little angry about the high and unpredictable cost of their medications. They want more than sympathetic words from their elected officials. They want swift, bipartisan action to solve the problem. And today, we're taking an important first step in the right direction. I want to close by noting that I think the process by which the committee put this bill together deserves credit. Not only is it bipartisan, but stakeholders had the opportunity to weigh in, and their feedback informed the bill writing process. I know there are a few remaining concerns about elements of the bill. There will be time between today's markup and floor consideration to better understand these concerns and determine whether or not tweaks may be justified. This is exactly how the legislative process is supposed to work, and so I commend the committee. I yield back.
Thank the gentlelady. Let me recognize the gentleman from New York, Mr. Swazi, to strike the last word.
Thank you, Mr. Chairman. I want to thank you again. This is our second bipartisan markup in as many weeks, and the fact that you're encouraging this type of work by this committee is to be applauded. I want to thank Ranking Member Brady, as well as all of my colleagues, for making this bipartisan effort on this most important issue that so many Americans are hungering for us to do something with. There's a lot more work that needs to be done, but working together, this hopefully will become a habit in this committee and throughout the entire Congress. This is a very complicated issue, but as President Trump, when discussing the pharmaceutical industry, said in January of 2017 before he took office, these guys are getting away with murder. That's a very simplistic way of looking at the fact that this is just so unfair to so many American people. We don't need to convince the American people that this is a problem. 80% of Americans believe that prescription drug prices are too high. And we learned during our hearing back in February 12th that America is the only country in the world other than New Zealand that permits pharmaceutical companies to advertise on television. Think about that. In the entire world, the only two countries in the world that can advertise on television are New Zealand and the United States of America. So it's not surprising that we also found out in our hearing that the pharmaceutical companies spend more money on marketing than they do on innovation and on R&D. And those TV commercials, as our colleague Brian Higgins pointed out, paint these very rosy pictures of sunshine and happiness and everything's wonderful and take this drug and everything's going to get better. And then what do they say? They say, go ask your doctor. So it was interesting to learn that pharmaceutical companies spend even more money marketing directly to doctors, taking them to lunch, buying lunch for the office, having conferences, going on cruises, having sales reps go to these offices and giving them incentives to use specific drugs, that they actually spend more money on this type of advertising than they do on advertising on television. This effort to provide more transparency will be a great step forward. There is so much more work to do, but if we keep on working in a bipartisan fashion, I hope that on this issue we can address a major concern of the American people, which is high prescription drug costs. Thank you, Mr. Chairman, and I yield back.
Thank you. The chair would recognize the gentleman from Texas, Mr. Arrington, who had influence on the direction of this legislation. The gentleman is recognized to strike the last word.
Thank you, Mr. Chairman. I'm still getting over the loss of Texas Tech and UVA, so if you'll just bear with me a little bit. It's tough on us Red Raiders. This is more important than a basketball game. This affects my mom and dad, who are seniors and who are Medicare beneficiaries, and millions of Americans. And we all know that the drug prices are too high, inordinately too high, and we know the system can be gamed in a way that is not in the best interest of our government, taxpayers, and patients. And there's tremendous benefit to the various stakeholders in the mix in terms of drug pricing. And PBMs are just one of the stakeholders in the supply chain. And every stakeholder in the supply chain has to be held accountable, and we have to look very closely at where the incentives are not aligned, but in fact are perverse in that they work for just that stakeholder and not all participants, and again, especially the patient. In a healthy market where you have competition and choice, you have bargaining power in the way of information that empowers the patient. And I think there's a lack of transparency and information to empower folks negotiating drug pricing. And so I think I was proud to be a part of the PBM Accountability Act with my colleagues, Representative Doyle and Spanberg. I think this is a step in the right direction, but I think there's a whole lot of substantive retooling of this so that the markets truly work in a way that produces the best value. I believe fundamentally that a healthy market produces the best quality of service and product at the lowest price. I don't think government will ever be able to divine that like a healthy, efficient market. But you gotta the patient and the government has to know what's going on, and so much transparency is needed, not just for PBMs, but I was proud to be a part of that PBM Accountability Act. We need to also, Mr. Chairman, make sure that as we are putting the proper reforms in place, including transparency, and in this case specifically, that we distinguish between administrative fees and rebate revenue. I think we've got to be very clear. Because even in that, there's a way to game this. So we want to get at the right information so that everybody can win, including the patients and taxpayers who we are all here to serve. Thank you, Mr. Chairman, and I'm supportive in general of this bipartisan effort to bring the price of drugs down. Again, a whole lot more to do, and I look forward to rolling up my sleeves with you, Mr. Chairman, and all my colleagues on the committee. Go Tech.
Thank the gentleman. With that, let me recognize the gentleman from California to strike the last word, Mr. Panetta.
Thank you, Mr. Chairman. I move to strike the last word and ask permission to submit into the record a letter dated April 9th, 2009 from Anthony Beretta, Senior Vice President, Government Relations of Kaiser Permanente, to the Chairman as well as Ranking Member Brady. In that letter, Kaiser Permanente, Mr. Beretta, specifically states that prescription drug prices are out of control and continue to grow at unsustainable rates. Mr. Beretta goes on to commend this committee and say that this legislation is a good step in addressing this problem based on two very important provisions in the STAR Act. The first one being that the legislation will require manufacturers to justify both high launch prices and large price increases. And the second provision, the requirement that manufacturers have to report the free samples they provide to physicians. As I said, Mr. Beretta states that this is an important first step, but he also ends by saying much more has to be done, and he looks forward to working on not just the STAR Act, but other legislation that has the potential to address what has become a drug price explosion that, if not addressed, will risk access for patients and communities who rely on such treatments. Thank you, Mr. Chairman. Once again, I commend the committee and I commend you for this legislation. Thank you.
The gentleman. Let me recognize the gentleman from Michigan, Mr. Kildee, to strike the last word.
Thank you, Mr. Chairman. Thank you for arranging this markup and for bringing this legislation forward in this committee. And I'm particularly, again, as my colleagues have said, pleased to see that we are working in a bipartisan manner. That may not be the case on every issue that comes before this committee, but when we do agree, it makes sense that we work together like this. And this is just one of those issues that I think we in Congress should spend more time on. These issues that are really often complicated policy questions, but fundamentally they're not complicated questions at all. These are the questions that American families talk about when they're sitting around their kitchen table. Access to health care, access to life-saving, life-changing prescription drugs is something that is not guaranteed. And the very notion that people can be priced out of access to something that could either change their life or in many ways save their lives is something that ought to be addressed and really should be an affront to every American, the notion that that still exists in this country. And it's the first step, I hope, of many. I know others have indicated that they wish we could go further. I think we will, but I think it's important that we have a start, and we have a start in a way that actually gets something done rather than just carves out a position. As my colleague Mr. Boyle noted, the study that the AARP released indicates that transparency is not just making sure people have a right to know, but information being openly shared, people knowing the underlying data and information around price increases and pricing of prescription drugs has an effect on how the market functions and can bring down those costs simply with that sunshine. And that's important to know, and it's important that we continue the further steps that will be necessary in order to make drug prices more affordable. I also think, in closing, it is notable that even with this modest set of steps that are important for sure and will be impactful, and in a bipartisan fashion with, at least so far, near unanimous support, there are still interests that oppose even these measures, which we ought to pay attention to, especially as more difficult questions come forward. If we can't get support from some who benefit from the status quo for something as logical, bipartisan, reasonable as the steps that we're about to enact through this legislation, that affects the way I will view future opposition to even more rigorous approaches to bring sanity to drug pricing in this country. So you had your opportunity to get on board with something important and bipartisan and reasonable, and by failing to recognize that, it affects the ability for us to take some of the criticisms of other more significant measures more seriously. With that, Mr. Chairman, I yield back.
Thank the gentleman. With that, let me recognize the gentlelady from Alabama, Ms. Sewell, to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. Today we're focusing our attention, this Congress, on alleviating the anxiety that so many of our constituents continue to face around rising health care costs in this country. And we know that prescription drugs are a significant driver of those costs. With today's bill, we're moving in the right direction, I believe. Chairman Neal and Ranking Member Brady, I want to thank both of you for holding today's markup. There are too many Americans who cannot access the medication they need to lead a productive life because they simply can't afford it. And that is simply unacceptable. And while patients are facing outrageous costs at the pharmacy counter, the Medicare program spent $130 billion on prescription drugs in 2016. We have an obligation to the American taxpayer to identify where costs can be saved. We have the responsibility to Medicare beneficiaries to reduce their costs as well. Now, my state of Alabama has the 6th highest retail prescription drug costs per capita. The 5 states with the highest rates per capita are also in the South. I would be remiss to not mention that there are also the same states that have the highest rates of chronic illness and poor outcomes. I have a lot of constituents, especially seniors, who are on 4 or 5 or more prescriptions a day. So it is very clear that while we work to reduce the cost of prescription drugs, we also need to make sure our system is rewarding value and reducing the need for prescription drugs on the front end through prevention. We will never get a hold of the problem if we don't also address the drivers of chronic illness in this country. I know that this is an important first step, but it's only a first step. I look forward to working with both sides of the aisle and with you, Mr. Chairman, in making sure that we continue to provide important legislation that will reduce the cost of prescription drugs throughout this country. Thank you, and I yield back the balance of my time.
Thank the gentlelady. Is there anyone else who wishes to be recognized for the purpose of striking the last word? Recognize the gentleman from Pennsylvania, Mr. Evans, to strike the last word.
Thank you, Mr. Chairman and Ranking Member Brady and colleagues on the Ways and Means Committee. I'd like to offer my support for the STAR Act of 2019. The rising cost of prescription drugs has truly placed an unduly hardship on all of our constituents around the country. This committee has held 2 hearings in this Congress regarding the rising cost of prescription drugs, highlighting the critical importance of this issue. Philadelphia is home to some of the best hospitals in the country. Just to name a few. We have the Children's Hospital of Philadelphia, the University of Penn Hospital, Jefferson University Hospital, Einstein Medical Center, Temple University, and Chestnut Hill. Both the doctors and patients of these facilities have come to my office asking, what is Congress going to do about these drug prices? Recently, I had a young man named Chase come into my office with his mom, Courtney, on behalf of the American Diabetics Association. Chase is 10 years old and was diagnosed with type 1 diabetes at the age of 3. I sat with Chase in my office, and he told me about how diabetes affects his body, the process of managing diabetes, and what it would mean if he did not have access to insulin to help control his blood sugar levels. The statement he left with me says, I want lawmakers to help lower the price of insulin because we can't afford it really. I want there to be a cure because diabetic is a dangerous illness. If there's a cure, it would mean my mom wouldn't need to spend so much money on supplies. This is what this bill is all about. This is what we are here today. If children like Chase and their families are paying the devastating cost of these rising drug prices, we have heard far too many stories of individuals and families across this country limiting their dosage, skipping medication altogether to keep costs down while putting their health at risk. We can have all the medical drugs in the world, but what's good if the people can't afford them? I understand this bill isn't going to solve the entire issue of drug pricing overnight, but I applaud its necessity and critical importance step in the right direction. By increasing transparency, Congress can have the information needed to help protect Americans from unreasonable drug costs. I appreciate having the opportunity to speak in support of this bipartisan legislation to help ensure that all Americans have affordable access to the medical care they need and deserve. Thank you, and I yield back the balance of my time.
Let me recognize the gentlelady from Wisconsin, Ms. Moore, to strike the last word.
Thank you, Mr. Chairman, and I want to thank the authors of this initiative for this very important work, and I want to give my unequivocal support to H.R. 2113. And I want to say for the record that I think it's an important first step with the emphasis on first. There are many, many issues to be worked out with regard to right-sizing pharmaceutical drug pricing. I think we are at some point going to have to take on the on executive pay. Just Google the top executive pay and you'll find executive pay somewhere in the area of $40 million per year for pharmaceutical executives. We're also going to have to really talk about negotiating drug prices for drug prices. It's just egregious that these drug prices in the United States are so much more here than they are in other parts of the OECD world. But I do applaud the authors for this first step. I personally am terrified that if we can't come to terms with these high prices, I take a medication that costs $18,000 per month. And I felt sorry for myself until I had a young man with hemophilia come to visit me from my district in my office to learn that he has a medication that costs $25,000 per week. No one can afford this, whatever their income or wealth or assets, and we have got to get this done on a bipartisan basis. This is not a Democratic issue or a Republican issue. This is a people's issue, and it should be our highest priority in this 116th Congress. And I yield back.
Thank the gentlelady and recognize the gentleman from Arizona, Mr. Schweikert, to strike the last word.
Thank you, Mr. Chairman. I'll try to do this fairly quickly. Look, what we're doing here is an incremental step. It has a couple things I would have designed differently, but ultimately, okay, fine. It's the right. Much of it is the right thing to do. I do want to sort of once again throw out, as our friend who just spoke about one of her constituents with hemophilia. Understand, we are very optimistic, maybe even by the end of this year, there may be a single-shot cure for hemophilia A. But it could cost, we don't know yet, but what if it cost $1.5 million for the injection? But if you actually think about the revolution that would be in a chronic condition that is extraordinarily expensive, it would be amazing. We, as we're having this conversation here, we're going to have a conversation about how we are going to finance these revolutionary biologicals that are coming, but they're going to be extraordinarily expensive. They're going to take care of often very small populations. My understanding is there may be in our country only about 8,000 those with hemophilia A, just as an example. We may also have to have a very complex conversation of what happens if we're heading towards a world where we may have substantially, well, it's probably not appropriate to call them cures, but revolutionary treatments for our brothers and sisters with chronic conditions, but it's very, very, very expensive. How do we price? How do we finance? Are we heading towards a time where we're going to have to do a healthcare adoption bond so we can roll out these types of cures as fast as possible? So understand, this is just the tip of the iceberg in a very complex conversation. But we're also going to have to think about the general formula. How about if that hemophilia drug, let's just pretend it's $1.5 million for the single injection, is done at a hospital. Are we about to give 6%? That would be $90,000 for doing that single injection under the current formula. So we're going to have to sort of think through, future-proof this conversation about the revolution that's starting to happen around us in these curative pharmaceuticals. And with that, I yield back.
We thank the gentleman. Is there anybody else who would like to be recognized for the purpose of striking the last word? Hearing none, the chair will now proceed to amendments. Are there any amendments to the amendment in the nature of a substitute? Chair would recognize the gentleman from North Carolina, Mr. Holding, to offer an amendment.
Thank you, Mr. Chairman. I have an amendment at the desk.
Has it been dispensed?
They are.
The gentleman is recognized on his amendment.
Mr. Chairman, I'm pleased that we're considering a legislation today with bipartisan support to tackle rising drug prices, and I think we all here can agree that certain actors across the pharmaceutical industry must be checked, and I'm supportive of provisions in this bill that aim to improve the kind of competition that can bring down costs for patients. Patients need better treatments, more affordable choices, and good information about the value of medical care, including the cost of prescription drugs. I believe that scrutiny should be placed on companies that implement extreme and difficult to understand price hikes for existing products. That being said, I believe the approach outlined in the STAR Act in some ways is short-sighted. Now, I plan to withdraw this amendment, but would like to outline some of my serious concerns with this approach, and I'd like to work with the chairman and the ranking member and the other interested folks here on this committee on language as the process moves forward in hopes that we can address these concerns before floor consideration. The pricing provision included in the STAR Act will require unprecedented reporting and justification from private companies when their products launch at a price above an arbitrary threshold. The intent of this bill should be to shed some light on manufacturers who are implementing unjustified price increases or acting irresponsibly in the marketplace. The intent should not be to bog down the good actors, manufacturers, the good actors who are manufacturers that are bringing to market some of the most innovative breakthrough treatments and therapies we've ever seen, ones that require extensive research and complex manufacturing. We need a system that rewards high-quality care while stopping abusive pricing practices. We need more thoughtful and effective deterrent that will stop the bad actors who buy up existing drugs, make no investments, and raise their prices to levels representing extortion. Unfortunately, setting a dollar threshold for transparency is completely disconnected from the value that a medicine has for patients. So my amendment is designed to keep the focus on bad actors rather than the people who are trying to bring cures to us. It is designated to strike a balance, recognizing the importance of companies that are working on drugs where patients are desperate for new treatments, such as rare or orphaned drugs. The first drugs approved by the FDA for indication or where the FDA has determined the drug represents a significant clinical advancement. The $26,000 threshold would still apply to drugs that do not meet any of these criteria. The United States is the leading innovator in the pharmaceutical industry, and these are the kinds of therapies and treatments that families want readily available when facing an immediate diagnosis. My goal here is to incentivize this type of research and not discourage it. At this point, I'd like to yield to my colleague, Mr. Schneider, for a few remarks.
Mr. Schneider is recognized.
Thank you, and I want to express my gratitude to my colleague for yielding. And let me make clear that I support the underlying legislation, but I do oppose the amendment. As so many people have already noted this morning, rising drug costs are placing increasing financial burdens on seniors and families and young people who are just beginning their careers as they leave their parents' insurance. Transparency is an excellent first step in our committee's work to address the rising cost of drugs, and that's reflected in each bill within this package and the fact that it has bipartisan support. While Americans want more accountability and transparency, currently none of us, not patients, not physicians, nor the government knows why a price of a drug might suddenly be twice as expensive this year compared to last year. Therefore, any bill that helps us shed light on our drug pricing system and eliminate at least some of the information asymmetry that currently exists will be widely beneficial. That said, I also believe that there's more we can do to further the goals of this bill before it hopefully gets signed into law. This is a top issue for my constituents and for Americans across the country. So it's crucial that we get each step, including this first step, right. Our legislation must expose the bad actors while continuing to foster the life-changing innovation that could provide the next breakthrough treatment or even cures for diseases such as Parkinson's, diabetes, or cancer. As we work to get this bill to the President's desk, it's important that we continue to work in a bipartisan fashion and solicit input from all stakeholders. We need to dig deep and broaden our perspective, especially as our committee starts to address the underlying drivers of prescription drug prices. Thank you again to the chairman, to my colleague for yielding, and to both the chairman and ranking member for bringing this bipartisan bill forward. I yield back.
Thank the gentleman. And the individual who offered the amendment has indicated that he is prepared, based upon recognition that the chair would work with him going forward, that he would withdraw the amendment. Thank the gentleman. Are there any other amendments? The question then is agreeing to the amendment offered by the chair. For those who please favor it, signify by saying aye. Aye. Those opposed, no. It's the chair's position that we're going to have a roll call vote on this matter. So the clerk will call the roll. No, on the nature of the substitute.
Mr. Lewis?
Yes.
Mr. Lewis?
Yes.
Yes. Mr. Doggett?
Aye.
Mr. Thompson?
Aye.
Mr. Thompson, aye. Mr. Larson?
Yes.
Mr. Larson, yes. Mr. Blumenauer? Mr. Kine? Mr. Pasquarello? Yes. Mr. Pasquarello, yes. Mr. Davis? Aye. Mr. Davis, aye. Ms. Sanchez? Mr. Higgins? Yes. Mr. Higgins, yes. Ms. Sewell?
Aye.
Ms. Sewell, aye. Ms. Delbene?
Aye.
Ms. Delbene, aye. Ms. Chu? Ms. Moore? Ms. Moore, aye. Mr. Kildee? Aye. Mr. Kildee, aye. Mr. Boyle? Aye. Mr. Boyle, aye. Mr. Byer? Aye. Mr. Byer, aye. Mr. Evans? Aye. Mr. Evans, aye. Mr. Snyder? Aye. Mr. Snyder, aye. Mr. Swazi? Aye. Mr. Swazi, aye. Mr. Panetta? Aye. Mr. Panetta, aye. Ms. Murphy? Aye. Ms. Murphy, aye. Mr. Gomez? Mr. Horsford? Aye. Mr. Horsford, aye. Mr. Brady?
Aye.
Mr. Brady, aye. Mr. Nunes? Aye. Mr. Nunes, aye. Mr. Buchanan? Aye. Mr. Buchanan, aye. Mr. Smith of Nebraska? Aye. Mr. Smith of Nebraska, aye. Mr. Merchant? Mr. Merchant, yes. Mr. Reed? Aye. Mr. Reed, aye. Mr. Kelly? Aye. Mr. Kelly, aye. Mr. Holding? Mr. Holding, aye. Mr. Smith of Missouri? Aye. Mr. Rice? Mr. Rice, aye. Mr. Schweikert? Mr. Schweikert, aye. Mr. Waworski, excuse me. Ms. Leworski, aye. Mr. LaHood? Mr. Winstrup? Mr. Winstrup, aye. Mr. Arrington? Mr. Arrington, yes. Mr. Ferguson? Mr. Ferguson, yes. Mr. Estes? Aye. Mr. Estes, aye. Mr. Blumenauer? Ms. Sanchez? Ms. Chu? Mr. Gomez? Mr. LaHood? Mr. Hood, yes. Chairman Neal?
Yes.
Chairman Neal, yes.
Would the clerk please report the tally? Chair would hold for just a couple of seconds. Ms. Chu is on her way.
Mr. Doggett votes aye. Yes.
Yeah, John heard me. I heard you too. They didn't. Okay. Well, talk louder.
Mr. Gomez?
Aye.
Mr. Gomez votes aye.
Rich is recording Judy's vote. Is recording Judy's vote the last thing we got. This was only.
You could do that on voice, though.
Okay, this was only on the substitute.
I'm going to recognize John.
For the standard motion. Got at 12 o'clock. That's if there's no other action.
Is she here? How is Mr. Kind reported?
Mr. Kind's not recorded. Mr. Kind, aye.
Are there any other members who wish to cast or change their vote?
I think so. I believe so.
Would the clerk please report the final tally here once more?
39 ayes, 0 nays.
Thank the gentleman. The chair would now recognize Mr. Lewis for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2113 as amended to the House of Representatives.
The question is on favorably reporting the bill H.R. 2113. If it's okay with the minority, the chair would recognize Ms. Chu to be recorded on the previous vote. It is. Ms. Chu?
Ms. Chu? Aye. Ms. Chu votes aye.
The clerk would then again report the score.
40 ayes, 0 nays.
Thank the gentleman. The question is on favorably reporting the bill H.R. 2113 as amended. All those in favor signify by saying aye.
Aye.
Those opposed, no. In the opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 2113 as amended is ordered favorably reported to the House. The purpose of this session having been accomplished without objection. The staff are authorized to make technical and conforming changes to the bill, and members have 2 additional days to file the committee clerk supplemental, additional, dissenting, or minority views. The committee stands adjourned.
Thank you, Mr. Chairman.
You should jump.
Yeah, well.
Yeah, it is.